Good morning. As many of you know, my name's Glenn McGurk, and I work on the Medicare Clinical Laboratory Fee Schedule policy for CMS in the Division of Ambulatory Services. It's our pleasure here at CMS to once again host the annual public meeting for clinical laboratory services. We would like to welcome everyone here, those that are listening in on the phone lines, and those watching our live stream. For those who will be presenting, we thank you for your prompt delivery of your presentations in the time frame requested. All of you should have received the information that was posted on our Clinical Laboratory Fee Schedule website concerning the new codes that will be discussed today. If you have any handouts, written comments, copies of your presentations that you have not already provided to me, please make sure you get those to me while you're here at CMS. We outlined in a Federal Register notice announcing the meeting that the public has approximately an additional 2 weeks to provide comments, which will end on about August 8th, after the meeting concludes. Each speaker will be given a maximum time of 10 minutes to give their presentation. Speakers should have provided extra handouts for those attendees interested in obtaining a copy of the presentation. Also, after the meeting, anyone interested in obtaining electronic copies of the presentations can request them by sending an email to me. And I'll give you my email address in a second. Please note that we will be discussing only the codes addressed in our Clinical Laboratory Fee Schedule CY 2018 update, which is found on our webpage. At the conclusion of each presentation, we will have a brief open forum for questions to presenters from those in attendance. Again, please direct any comments toward the presentations regarding the new codes for 2018 that will be discussed. We will not be discussing any policy decisions during this meeting. In summary, after this public meeting, we will continue to accept public comments for approximately 2 weeks, which ends around the 8th to the 11th, somewhere around there. Then we will determine the basis of payment, either crosswalk or gap-filled, for the test codes that we determine to crosswalk, the amount of payment for the new test codes, and then we will post that information on our website as soon as possible. We're aiming for September like we always do. At that point, we will accept and consider additional comments. The basis of payment and the amount of payment become final at the same time that we issue the annual CMS instruction for CY 2018, approximately mid-November is our goal. Then the public has 60 days from the date we issue our annual instruction to request reconsideration of either the basis of payment or the amount of payment for these new test codes. The public may comment on any reconsideration requests at the next annual public meeting. In addition, for any new test code that will be gap-filled, we ask our Medicare contractors to develop carrier-specific gap-filled amounts by April 1st of the following year. These amounts will then be finalized on September 30th of that year. Unlike a crosswalk test, the payment amount for gap-filled tests is not established when we determine the basis for payment because it takes approximately 9 months for our contractors to establish carrier-specific amounts. After these prices are developed by the Medicare contractors, we will post them on our website and accept comments for 60 days after April 1st. Not reconsideration requests, just comments. Later in the year, when the gap-fill payments amounts are posted on the website as final, we will accept reconsideration requests on the gap-fill payment amounts for 30 days. Once the reconsideration process is completed for a cycle, the determination is final and would not be subject to further reconsideration. In addition, the new private payer rate-based payment system for the CLFS will be implemented on January 1st, 2018. We will post the new preliminary CLFS rates at the same time we post the preliminary determinations for new and reconsidered laboratory HCPCS codes, and will apply the same public comment period and final determination process. Lastly, following today's presentations for the new and reconsidered codes, we would like to have a brief discussion regarding certain laboratory codes on the fee schedule that are very rarely billed to Medicare. We would like to get the public input during the comment period that immediately follows this meeting on whether or not the code should be included on the CLFS, Clinical Lab Fee Schedule. This issue is not listed on the agenda, but we wanted to bring the matter to your attention, and we'll discuss it in further detail when we get to that part of today's meeting. As for housekeeping issues, please note the following. If you would like a copy of the agenda, it's online. I didn't bring hard copies, so I apologize for that, but it is online. The restrooms are located, if you don't know, outside this room toward the lobby on the left before you get to the lobby. There's also a water fountain there. Cafeteria, for those that don't know, is located lower level from the lobby in the back of the building. You get there either by the elevator or stairs. For taxi service, the guard desk in the lobby where you signed in can provide assistance. For those of you who may not know, CMS is a smoke-free campus. Please place your electronic devices on silent or vibrate. And for teleconference participants, please place your phones on mute. For any comments or questions, please step up to the microphones provided on the floor so that all may hear you. Comments or questions have a 5-minute limit. If you have any additional questions during the course of the time we are meeting here together, please do not hesitate to see me. And if you need to contact me after the meeting, I'd like to provide you my contact information. You can reach me. Again, my name is Glenn McGurk. It's McGuirk at 410-786-5723. My email address is glenn.mcguirk@cms.hhs.gov. So before we begin the presentations, I'd like to introduce the management team of the Division of Ambulatory Services, if they're here. Valerie Miller, who is our director. She was running late, so, okay. Sarah Shiri-Loso is deputy director. You may have seen her. She was taking your autographs at the front door. I'd also like to welcome Dr. Karen Nakano, the chairperson for the Clinical Diagnostic Laboratory Test Advisory Panel. And finally, the director for the Hospital and Ambulatory Policy Group, Carol Blackford. Director Blackford will now say a few words. Thank you.
Thank you, Glenn. Good morning. I recognize that we have a very ambitious agenda today, so I want to take only a few minutes of your time this morning to express our appreciation for the members of the public and our panel members for attending this important meeting on payment methods for new and reconsidered clinical diagnostic laboratory test codes for the 2018 Medicare clinical lab fee schedule. We sincerely appreciate the public and the panel's expertise, and we value your contributions to improve CMS policy by strengthening the connections between Medicare payments and high-quality, efficient care for our beneficiaries. As you know, the law requires CMS to hold public meetings to receive comments and recommendations from the public regarding the basis for establishing payment amounts for new or substantially revised HCPCS lab codes. And we've been holding these public meetings annually for the CLFS since 2005. We have long recognized the importance of the public's role in developing effective policies, including the assistance of our advisory panels. Our Clinical Diagnostic Laboratory Test Advisory Panel, which is also required by statute, Section 1834A-F1 to be exact, was chartered in 2015, and this is its 4th meeting. Advisory committees ensure that public involvement and expert advice are part of the federal policymaking process. As Glenn mentioned, the statutory landscape has changed a bit since we first started these public meetings back in 2005. Section 1834A of the Act requires a new payment method for tests on the clinical lab fee schedule, and beginning on January 1, 2018, in general, the payment amount for a test on the fee schedule will be calculated based on the rates that private payers pay for the tests. And for tests for which we receive no private payer data, the payment amount will be based on crosswalking or gap filling. Applicable labs were to report private payer data to CMS by March 31st. And on March 30th, we announced that we would exercise enforcement discretion until May 30th, 2017, with respect to the data reporting period for reporting applicable information under the clinical lab fee schedule. That period has elapsed, and we are analyzing all of the reported data as we speak. And we continue to expect to publish preliminary CLFS rates for calendar year 2018 in September, with a public comment period of approximately 30 days, the schedule that Glenn walked you through. So the public meetings continue to be a vital part of establishing payment amounts for new or substantially revised HCPCS laboratory codes. So to the public and the panel members, again, we sincerely appreciate your invaluable contributions of professional expertise and experience to this public process behind our clinical lab fee schedule. Now, before I turn this back over to Glenn, I want to take a moment to thank Catherine Estridge, who handled the travel logistics for our panel members, Rashida Johnson and Glenn and the CLFS team for all of their hard work in pulling this meeting together, and for Dr. Karen Nakano and our medical officers for their clinical expertise and their guidance. So thank you again, and we look forward to your input today. Thank you.
Okay, let's start the presentations. Our first presenter is Karl Silavka from Atlantic Diagnostic Laboratories.
Good morning. My name is Karl Silavka. I'm one of the directors at Atlantic Diagnostic Laboratories. We're a regional provider of full-service clinical provision as well as forensic toxicology located in Bensalem, Pennsylvania. Bensalem is just a little north of Philly and just over the border from Trenton, New Jersey. In partnership with Metabolomics Technologies Incorporated, we were awarded CPT PLO code 0002U effective 1 February of this year. This prescribed notation is for the Polyp DX test, which is designed to provide for the first time proactive diagnostic information that will allow folks to know whether they have present polyps, adenomatous polyps, which could be precursors to colorectal cancer. This is assisting for the first time, we believe, moving healthcare forward from where it was in the past as a reactive description of what physicians tried to do best for their patients to a proactive position of being able to identify the presence of adenomatous polyps, which might lead to CRC, a very critical disease for the general population. To summarize the assistance provided by the laboratory and our technological partner, MTI, we performed testing for 3 biomarkers, succinic acid, ascorbic acid, and carnitine using liquid chromatography with tandem mass spectrometry in the MRM mode. That is then taken forward as data points along with demographic information from the patient, including their age, their sex, and their smoking history, taken through an algorithmic process, and then the threshold used to diagnose whether the results from our Polyp DX test are likely to be descriptive of the presence of adenomatous polyps or not is used to take forward the patient to either have additional care provided by colonoscopy, by GI specialists, or to give them the peace of mind that comes from a negative Polyp DX test result. To give you a summary of the pre-current and post-analytical strategies and all of the steps involved, essentially a collection of a midstream urine void as opposed to blood or feces is used to test this individual in a pre-diagnostic position, if you will. In order to preserve the integrity of the sample, we use light-tight containers, normal collection in a cup, followed with transmission to this device, which is sent to the laboratory on ice. Although we're a stat lab and they're 24/7, 365, to lower the cost of the overall testing, for your consideration, of course, we wanted to make sure that this is a light-tight container put on ice so that we can have a 2-day shipment to the laboratory, take some of the cost out of the test. I brought along a device in case any of you have not had good care developed yet for you this year. I'll take a sample back with me. We'll provide it gratis.
Sounds like
Sorry, that was a joke. I will do it for free, though, if you want me to. After the sample's been collected, it reaches the laboratory. Full-scale accessioning is performed in order to get the demographic information in accurately and to meet HIPAA requirements for confidentiality. That's then taken to the laboratory. We perform a complicated process using LC-MS. Two of the analytes lend themselves to negative ion MRM analysis. One of them is Zwitter ionic and therefore needs positive ion analysis. The chromatography is a little complicated, but I'm an LC guy, so it's no problem for me. That information is then taken forward into the algorithm with the demographic information taken through a logarithmic process on the intellectual property platform provided by MTI. The results at the laboratory are reviewed by 3 individual sets, goes forward to the algorithm, gets reviewed by another professional, then it gets to the clinician thereafter. We also harvest and hold in an archive the data from large pools of data in order to improve the threshold that's used to set differences between presumptive positive findings, which would lead a person to get colonoscopy from a GI professional, and presumptive negative findings, which would give you the peace of mind that you probably do not have the issue arising for you in the next year or so at least or more. Polyps are precursors to CRC and have about a 10-year latency for some of these polyps, so we have a good deal of time. In the old days, we had to react to discovered CRC. With this new Polyp DX test, what we're allowed to do diagnostically is provide proactively testing information that allows us to avoid the development of cancer. The costs involved, of course, are much lower when you have not yet developed a disease to have a polyp removed by colonoscopy rather than discovering you have CRC and have to take that forward with the expensive and invasive treatments that must be provided. I've given you too much information to have to re-speak it for you, but essentially a presumptive positive finding on this test leads you to get additional care from GI specialists. A presumptive negative test finding is going to give you additional information and peace of mind going forward with your own life. The costs that were associated with this test are embodied for you here. There is intellectual property costs. Dozens of people spent dozens of years developing the technology that's used in the algorithm placement of our data and the demographic information through for a patient to determine whether they meet or exceed that threshold or are below that threshold for diagnostic indications. We also have laboratory and sample collection costs that have to be met, the multiples reviews that have to be done, the archiving of that data, and of course the sales and marketing of a test like this to get it to the right people for the right reasons at the right time. The cohort populations under cancer specialist determinations is if your family has CRC historical issues that you're trying to address younger, usually between 40 and 74, you need to have these kinds of tests done quite routinely. If your family does not have that history, the cohort suggests from the cancer specialist 50 to 74, you should have this testing done quite routinely. The difference between the old days where you had to get colonoscopy done and the 1 to 2 days of invasive materials that you have to drink and eat and things you otherwise have to do, now with a simple midstream voided urine, you can get the initial indication of whether colonoscopy is appropriate for you or not, whether you're in the high-risk population cohort or the lower-risk population cohort. If you haven't had the luxury of having colonoscopy lately and may have forgotten what it involves, it's not so much fun. It's a lot easier to give a urine sample and move forward on a negative test, or with a positive test, you have more surety that you're doing the right thing and that that invasiveness is in fact appropriate for you at that time. You asked us for some data. We provided here 2 rock charts that give you specificity and sensitivity in 2 large population studies that have been published. Usually we provide publications so that you sleep well at night. These are publications you would not sleep well because they're so exciting, and the data provided demonstrates the difference between the old days of reactivity and the new day of proactivity on avoiding colorectal cancer. There are more publications in C2 with review process right now. Whatever you'd like, I'll hand it to you. I promise you, you won't want to read it at night because you won't be able to sleep after that. All things sound good theoretically, don't they? Tests that are new, that have never been used on large populations of real patients in your communities, they sound good. like most laboratories, we have almost 200 employees. The first thing we wanted to do is make sure that we had a seamless process in order for getting the samples, appropriately accessioning them, doing the things into the demographics, getting the algorithm to work smoothly. So we offered this to everybody in the laboratory who would give a voluntary sample. Almost everybody did, because we all want to know where we are. Some of us are old farts and should have been tested and hadn't been yet. Provided the samples. One of the employees on our staff, a 43-year-old man in good health, no family history of CRC at all, had a presumptive positive finding, went to a GI specialist at Thomas Jefferson University who found a 1.5 to 2 centimeter polyp, removed it, and said to us, in 2 to 5 years, this would have been cancerous. So in our own hands, in our own population of colleagues, we had the demonstration that this is not just a good idea, it's an excellent new tool that moves us from the old medical care treatment system of find it and treat it to one that now removes the probability that we're going to have that occur in the first place, avoidance and health maintenance, which is what the new healthcare system is desired from all of us. Ultimately, I'm asking you to consider this for Gapfill. There is no technology that we are taking the place of or that competes with this. If you wanted to do blood and other invasive procedures with fecal material, you'd be detecting colorectal cancer. We are avoiding the development of colorectal cancer by finding polyps early in their generation and livelihood within your body before they become cancerous. So there is no crosswalk. This is a Gapfill strategy that we're suggesting. Again, a presumptive positive gives you the peace of mind that you do not need to subject yourself to more invasive procedures like colonoscopy, and you therefore can maximize the healthcare benefits of the money spent and minimize any colonoscopy risks that come along with these kinds of strategies being employed for real patients and their lives. I very much appreciate your attention to my presentation this morning. I'm honored that you gave me the first presentation so you could start with exciting news. Thank you very much.
Anyone have any questions, issues?
Just one question real quick. The $475, is that the lab cost or is that the charge?
It's the total cost, including the intellectual property costs. We built everything into that charge.
Okay.
For your consideration.
Thank you.
Thank you, sir.
Okay, one other housekeeping thing. We will be taking a lunch at noon. Okay? We may do a break at 10:30. We'll see how it goes. See how everyone is feeling at 10:30. We could do a 15-minute break. But from 12 to 1, we will take lunch. So, okay. Our next speaker is Michael Donovan from Exosome Diagnostics.
Good morning, and thank you very much for the opportunity to present to the group today. So my name is Michael Donovan. I'm a Senior Medical Director at Exosome Diagnostics, and I'm also a Professor of Experimental Pathology at Mount Sinai in New York City. So we'll be presenting today the EPI test. And so the background on the ExoDx Prostate IntelliScore, or known as EPI. We have been awarded a new code, the PLA 0005U. The new code descriptor oncology prostate gene expression profile by real-time PCR of 3 genes with a urine test algorithm and reported as a risk score. And our recommendation is to crosswalk to code 81539, oncology high-grade prostate cancer biochemical assay for 4 proteins, which is total protein-free PSA, intact PSA, and human kallikrein. And that utilizes plasma or serum in a prognostic algorithm and reported as a probability score. So just to give you a little background on the importance of exosomes in biology today. So exosomes are microvesicles secreted by all living cells into all biofluids. So all of the fluids in your body contain exosomes. Actively released by both eukaryotic as well as prokaryotic cells, and has certain advantages with respect to cell-free DNA and other ways to evaluate molecular markers in fluids, primarily because of the physiologic process which represents the production of exosomes. They're important messengers carrying comprehensive molecular information such as RNA, protein, and DNA. And they demonstrate an important biological system role with respect to intracellular communication in oncology, specifically with modulation of the extracellular environment with angiogenesis, stimulating cell growth, facilitating metastasis, and blunting the immune response. So a whole host of processes that are responsible with respect to exosomes, and there's quite a bit of literature supporting the exosome story today in biology. Key roles in many diseases, including immune, inflammatory, endocrine, neurodegenerative disease, and cardiovascular. And the key important piece is that exosomes are highly stable under a variety of conditions, which supports their ability to be able to isolate and then analyze in a variety of applications. The clinical problem statement for prostate cancer with respect to what's currently going on in clinical practice is serum PSA has a considerably high false positive rate, so men often undergo additional, more invasive tests to be able to determine the appropriate treatment course. Nature of tumors in the course of treatment, of course, has been quite different and widely variant depending upon the population and the geography. There's a high degree of indolent low-risk disease versus aggressive disease, which is really the clinical importance of why you actually proceed with some of these assays. The number of positive biopsies is increasing. However, the high percentage of men actually are diagnosed with either low-risk disease or benign or other processes which are not cancer-related within the prostate. Of course, there's considerable complications with respect to the biopsy process itself, including bleeding, incontinence, impotency, and severe infections, which have only increased over time. So there's quite a bit of overtreatment with respect to prostate cancer currently available. So 50% are treated, most men are treated with surgery, radiation at diagnosis, and 100,000 men with low-risk disease are treated unnecessarily. And there is a mortality rate which has stayed fixed with respect to prostate cancer. So high-grade disease has been the aspect that has been necessary with respect to managing men with prostate cancer and trying to identify that. The test purpose key differentiators with respect to the assay that I'm speaking about, it's a binary result, so it's a yes or no answer with respect to the urologist and specifically for the patient as well. No standard of care factors are added to the risk score to improve performance, which is a critical aspect of being able to use this and implement it in clinical practice. Test result provides a standalone value for clinical practice, and the results are easy to translate into patient management with no gray zone result. The ease of use in clinical practice is quite considerable. There's no DRE required, so there's no introduction of a DRE to be able to prior for collection of the sample. It's a simple initial urine collection with no manual manipulations or time restrictions, relatively quick results, and straightforward with respect to the patient discussion. So just going through the biopsy process itself, the intended use population is men 50 years or older with an equivocal PSA between 2 and 10, presenting for their initial first biopsy. The urologist visit, again, it's a non-DRE urine sample, first catch, which is collected in the office and that's shipped overnight to the Exosome Diagnostics lab. Then there's a patented process for isolating the exosomes, the RNA, performing an RT-qPCR, and then using a multivariate algorithmic analysis to be able to discriminate risk. And that's differentiating low risk, Gleason less than 6 disease versus high risk disease or Gleason 7. So the test method and lab workflow detail, it's quite involved with respect to processing the samples. So we're going from a 20 ml urine filtered sample, which is filtered in the lab, and that's to remove cell debris as well as other particulate material that's within the urine sample. Or urine samples are spiked with an isolation process control. Exosomes are isolated, washed, and then concentrated using proprietary technology. The RNA is isolated following reverse transcription of each sample, and then we're using a RT-PCR analysis of 3 genes, SPDEF, PCA3, and ERG. And a positive control patient-derived pooled urine sample, which expresses all genes, is included in every run. The QRPC data is converted to a risk score, which is risk-dependent cut points using the proprietary algorithm. That gives you the binary output of the test itself. The EPI score is incorporated into a test report, reviewed and approved by the laboratory director. So the clinical study history has been quite rigorous with respect to the use of this assay. Approximately 4,000 patients have gone into various EPI clinical trials to date. We have 2 prospective U.S. clinical validation studies. There are 1,500 patients in the initial study, and then an additional 500 patients that have just recently been completed. The first validation study results were published in JAMA Oncology in July of 2016. So 5 major data presentations have occurred since during the evolution of the EPI test itself. ESCO-GU 2015 final training cohort results, and then an interim analysis of the primary validation study. And then the final validation study results were presented at AUA at the key lecture. AUA 2016, we did a 3-year follow-up data from the primary validation study. And then we also presented at the AUA just recently is the interim analysis from the second validation study. So results from that second 500-patient prospective clinical validation study confirmed test performance with respect to what was reported in the JAMA Oncology paper itself. So from the data from the original validation study in JAMA Oncology demonstrating the performance characteristics of the EPI versus EPI plus standard of care, which is the age, race, PSA, and ethnicity, you can see that the EPI alone actually performed quite well with respect to discriminating high-grade disease from Gleason 6 and benign disease, especially when compared to PSA, which has an AUC pretty much as a flip of a coin. So the crosswalk to code 81539 seems appropriate based on similarities with respect to function and resource use. The test purpose code 0005U, crosswalk to code 81539, both predict the presence of high-grade disease with respect to men 50 years or older with a PSA of 2 to 10. So it's really the discrimination of high-grade disease from Gleason 6. They're both liquid-based tests, urine versus blood. Exosome RNA expression of 3 prostate cancer-related genes versus 4 kallikrein proteins, and both using a multivariate algorithmic analysis to be able to port a risk score. So there's comparability with respect to the assays in that crosswalk to the 81539. So the recommendation 0005U to existing 81539, the rationale crosswalking used if CDLT is comparable to an existing tests on the CLFS. 0005U is comparable to 81539 due to similar purpose of predicting high-grade prostate cancer using a liquid sample, close number of analytes, 3 genes versus 4 proteins, and the use of a multivariate algorithmic analysis to determine a result reported as a risk score. Thank you very much. Yeah, sure. Sorry.
Any questions? Yes, sir.
Thank you very much.
Sure, Raju.
Is there a correlation between the Gleason scores that you would obtain from pathology and your assay?
So that the design of both the validation study that was published is really based on that correlation with respect to the biopsy scores. So I didn't show the waterfall plot, but you actually can correlate the score itself with respect to the actual score, the Gleason score. Thank you. Sure. Thank you.
Okay, a couple things. Folks that are on the phone, please be sure to place your phones on mute, please. Also, a couple things were left at the sign-in in the lobby. There were a pair of sunglasses and a receipt from a taxi cab. Not sure if you need to get reimbursed for that. So, our third speaker is Claudia Stemple from NanoString Technologies.
Good morning. I'm Claudia Stemple from NanoString Technologies, and I'm here to talk today about Priscilla. This is probably going to be the easiest presentation that you have to listen to. Priscilla is a breast cancer assay. We currently have an administrative CPT code 008M, and we've had it since 2014. It is an analysis of 58 genes using hybrid capture on FFPE tissue. It's a prognostic algorithm reported as a risk score. It is 50 content genes and 8 housekeeping genes. Priscilla is FDA cleared and performed pursuant to the label and its intended use. It's a qualitative analysis utilizing gene expression data weighted together with clinical variables. It generates a risk category. While slight modifications have been made to the code descriptor 008M to our proposed level 1 CPT code of 815 in that series, the assay has not changed in any way. Our recommendation is to crosswalk 008M to our new level 1 CPT code. Currently, the 2017 clinical fee lab schedule, we are reimbursed at $3,443.36, and we are recommending that we be crosswalked to the same amount in 2018. This recommendation is consistent with historical CMS pricing determinations. Thank you very much. Any questions that I can answer? Yes.
So you had a Appendix O MA, and so you got FDA cleared, so you've got a now Category 1 code. Is that what you're recommending? Why the crosswalk?
We have been FDA cleared since 2014, and with our administrative code, we were FDA cleared.
So why are you going from an administrative code to the Category 1 MAAA?
So we were given the level 1 code for just consistency in payment from commercial and Medicare and Medicaid payers, and due to the volume increase. Any other questions? Okay, thank you.
Our next speaker is Rich Stripp from Cordant Core.
Good morning, everyone. I'm Richard Stripp. I'm from Cordant Health Solutions. I'm the Chief Science Officer for Cordant. I'm also a professor of forensic and clinical toxicology at the City University of New York. And this morning I'm going to be talking to you about a new method for oral fluid testing that we call CORE, Comprehensive Oral Fluid RX Evaluation, which has the code 0011U. And the actual code is a prescription drug monitoring tool for the evaluation of drugs present by liquid chromatography, tandem mass spectrometry using oral fluid as the matrix. And it's then reported as a comparison to an estimated steady state range per date of service. So the difference here is that we're not just basically detecting the drug in the oral fluid, but we're also comparing it to a steady state range. So the purpose of this particular method is to monitor drugs in oral fluid similar to the way you would do so in plasma, but using oral fluid, which is an easily collected matrix. It's observed, so it doesn't have some of the issues associated with urine with regards to substitution and adulteration and so forth. But the principal benefit here is that basically we're able to estimate what the steady state range is for patients that are being prescribed drugs chronically. This has been attempted many times in the past. A lot of the issues that they've had in the past have been that they used drugs that were not being administered chronically, or they didn't account for pH and things like that. So we've developed a method that actually is an individualized for the patient that's based upon various conditions. What this actually can do is it can help document whether the patients reach that expected steady state based upon the current dosage and frequency of the dose of the drug. And then basically provide information regarding whether there's an issue with metabolism, whether the patients may be deviating from dosing regimens, so health status. There are a number of reasons why a patient may actually be falling outside of steady state. We're suggesting that this crosswalk with the G0480 with a multiplier of 1.5 times. Basically, the test is very similar to the G480, which is the definitive test for drug identification methods that are able to identify drugs basically by mass spectrometry-based analysis. The difference here is that in addition to the LCMS methodology for the definitive testing, we're also doing the pharmacokinetic calculations to determine whether they're at steady state. So there's the added cost associated with the collection device that had to be designed, as well as the follow-up with the toxicologist and the additional text time that's required for the test. Basically, the multiplier of 1.5 is recommended for core because of, not only because of the cost associated with the test itself, but also the developmental cost. This basically took about 5 years to develop with our clinical partners. So basically, we have invested in development of an actual oral fluid collection device. One of the important aspects of doing the comprehensive oral fluid evaluation is you need to know the oral fluid pH at the time of collection. So a specialized collection device had to be developed for that as well. Because drugs basically are either acidic or basic drugs that have functional groups, the concentration of the drug in the oral fluid is going to be exponentially affected by the pH. So we developed an actual oral fluid collection device that allows for measurement of pH at the time, and in doing so, we can determine whether the patient's at steady state. And again, there are a number of reasons why they would fall outside of the steady state, which is of great value to the clinician, whether it be non-compliance, metabolic issues, issues associated with health status. The patients may not be taking the drug chronically, and they may not be at steady state. But all of that basically will provide information to the clinician, which then will help with their assessment and management of that particular patient. Any questions?
Edith Hambrick, CMS. Just a question about you said the costs are in line with 1.5 times GO480.
Correct.
So your test actually determines the levels for all the codes that would be in that GO series, if present.
Yeah, basically, the definitive test would test for any drug that basically you would normally test for by GCMS or LCMS. The additional this particular crosswalk would be associated with prescribed drugs that are being prescribed chronically, so that then you would use the same LCMS method to actually determine the concentration of the drug, but then you would follow up with the algorithm to determine whether they fall within the steady state.
So are these only for prescribed drugs and not for illicit drugs?
That's correct, because these are only for drugs that are prescribed that are at steady state. Say, for instance, if it's a pain medication, or it could be potentially something, a behavioral health med. Things where compliance are an issue, things where you're concerned about whether they're taking the drug as prescribed and so forth.
So what's the approximate number of drugs that you test for?
Right now, we have 7 of them, and we're expanding that as we're moving forward, because basically the method is not specific to any one drug. It's for any drug that basically is impacted by and secreted into the oral fluid. So it would be for any possible drug that we could potentially monitor.
So are there any drugs that are not secreted into the oral fluid? I'm just trying to get a universe
Well,
here.
I mean, some drugs, we have some difficulty in doing the core method if they're, say, for instance, if they're administered sublingually because of oral contamination. So something like Suboxone, this would not apply. We'd have to use a blood for something like that. But for drugs that actually are secreted into oral fluid, even at very low levels, because basically the algorithm actually accounts for the binding to plasma proteins. So highly bound drugs have very low concentrations in oral fluid. We're still able to do it because basically even at the concentrations that we detect them at, we have sensitive enough methods to do that.
Okay, thank you.
Yes.
Hi, Karen Nakano, CMS. Quick question for you. So is it fair to say that the cost, the 1.5 times G0480, when you mentioned the need to develop a device, a collection device that checks the pH of your sample, is it fair to say that that is a form of specimen validity?
It's not a form of specimen validity because basically what you're doing with the device, the pH is part of the calculation for the pharmacokinetic test. Indirectly, it actually could be considered to be also a validity test because pH has a great effect on oral fluid concentrations. So if there was any kind of adulteration, if they were basically trying to put an antacid in their mouth or something like that to drive the concentrations lower, by measuring pH, you'd be able to see that, but that's not the intention of the collection device. The intention of the collection device is in order to do the calculation, you have to know the pH. It's part of the calculation.
Okay, great. But you ultimately need to know the pH to know if the specimen was valid, correct?
Nobody is doing that today for validity testing. That's in urine. That's correct. But in an oral fluid, no.
Okay. Thank you.
Our fifth speaker is Mark Ryan from MDX Health.
Good morning. My name is Mark Ryan. I am with MDX Health. I'm going to compete with Claudius Temple for the most straightforward presentation this morning. Here today to speak about the new CPT code for Confirm MDX for prostate cancer. Before we get started, I do need to mention, because we are a publicly traded company, my brief discussion this morning may contain forward-looking statements, so please take that under advisement. As I mentioned earlier, we're here to discuss code 815X1 for the proprietary methylation-specific PCR tests that are used to deliver the Confirm MDX prostate results. It's worth mentioning that this test is in the NCCN Guidelines in 2016 for prostate cancer early detection. In order to discuss the purpose of the test, I'd like to briefly describe what's happening right now with patients that are suspected of having prostate cancer. About 1.3 million prostate biopsies performed in the United States. A little over 1 million of them come back negative. The issue with this, with a patient that has persistent symptoms, is that there is a well-documented false negative rate for prostate biopsy between 25 and 30%. So the issue is you have a patient with persistent symptoms, the prostate biopsy came back negative, so it's quite common to get repeat biopsies. And you'll see your study was published by Dr. Resnick in 2011, showed that even upon second and third prostate biopsies, clinically significant cancer was detected, clinically significant being defined as a Gleason score of 7 or greater. The reason this happens is because a standard 12-core truss guided biopsy accesses less than 1% of the tissue in the gland. So it's quite easy to miss the cancer. Confirm MDX for prostate cancer detects epigenetic activity that happens around these nesting tumor cells and is associated with an increased risk of presence of cancer. And so in running the test, which is done on each individual core, if methylation is detected, we can provide prostate mapping. So if the urologist decides to have a repeat biopsy for that patient, he or she can concentrate extra cores in that area. More importantly, arguably, is when the test comes back negative, that carries with it a 96% negative predictive value for clinically significant cancer, and therefore can lead the patient to a better peace of mind and the physician to possibly decide other options aside from a repeat biopsy. All of the cost information was submitted to the MolDX program when the allowable rate was established in 2014. These were done, allocated over a delivery of 5 years post-launch. There have been no technical or process changes to the test since that time. And we will be happy to provide, because we're a publicly traded company, the cost information on a confidential basis to CMS upon request. We respectfully recommend Gapfill for this code. There are no appropriate analogs in the CLFS among Tier 1, Tier 2 genomic sequencing procedures or MAAAs. The test is, again, a proprietary methylation-specific PCR process and employs a unique algorithm that are not like any other technologies or algorithms evolved in other MAAA codes. Are there any questions?
Our next speakers are William Auda, I'm sorry if I got your name wrong, and Bastian Vanderman from Agendia.
Thank you and good morning. I'm William Audi. I'm the Chief Medical Officer for Agendia and a medical oncologist. Thank you for the opportunity to present to you this morning. We're here to discuss the Agendia test MammaPrint 70-gene breast cancer recurrence assay, which now has a new code, 815X2. This is a breast cancer recurrence assay, an mRNA microarray gene expression profiling of 70 content genes and 465 housekeeping genes, which is utilizing either fresh frozen or now more commonly formalin-fixed paraffin-embedded tissue from the breast cancer sample itself, with an algorithm reporting an index which relates to the risk of distant metastasis as a binary readout, low risk or high risk. This test is FDA cleared with one de novo 510K clearance and then 5 consecutive FDA clearances, with the intended use in early stage breast cancer to determine prognosis and therefore assist in the determination of the need for chemotherapy in individuals with breast cancer. The test in the U.S. Is performed in the central laboratory located in Irvine, California, CLIA certified, CAP accredited. You can see the accreditations here and compliant with QSR, GMP, and inspected by the FDA. Now, this test has been studied now in over 60 studies. Data on its performance has been published in more than 100 publications over the years, most recently with a large, in fact, the largest prospective randomized trial utilizing an assay of this kind in breast cancer, published in the New England Journal last year with over 7,000 patients. One of the primary findings and the importance of this test is that 75% of individuals, of course primarily women, with estrogen receptor positive breast cancer are found to have a low risk score by the MammaPrint assay and therefore may safely avoid unnecessary chemotherapy. As a result of these studies, this test is now approved and endorsed by clinical guidelines, particularly the American Society of Clinical Oncology, but also NCCN here in the US, as well as several European guidelines, including St. Gallen and ESMO and others. MammaPrint is covered by Medicare and many other payers. The charge is $4,200. The Medicare allowed amount, $3,416. For the remainder of the presentation, I will hand this over to my colleague.
Thank you very much. My name is Bas van der Baan, Chief Clinical Officer. So, as Bill already indicated, the test is performed either on fresh frozen or fresh or FFPE tissue. We have individual FDA clearances for all analytes. We also have FDA clearances for pre- and post-menopausal women. Agendia prepares H&E stained slides, and a qualified pathologist actually assesses the tumor cell percentage. Our FDA clearance states that we need at least 30% invasive tumors to run the assay. Total RNA is isolated and amplified and labeled with a fluorescent dye, and the amplified labeled RNA is hybridized on a microarray. A scanner scans the DNA microarray, which contains thousands of genes, and generates a result. Proprietary software extracts the information from the scan and determines the quality. We're using 70 genes. They're printed 9 times on the microarray for quality assurance, and then we use 465 non-cancer related genes for normalization. We use all that information together to calculate the MammaPrint index, which results in high or low risk of distant recurrence. And as we showed in the MINDEC prospective randomized trial, what we see if clinicians consider chemotherapy, but our MammaPrint result is low risk, those patients have an excellent survival at 5 years, and also adding chemotherapy did not increase their survival. And as stated earlier, 3 out of 4 early stage breast cancer patients are low risk with our assay. The index is provided in a result form that goes to the clinician stating the risk category. So we recognize and concur with CMS that there is a preference where possible new tests should be crosswalked. We are looking at a number of comparable elements here. It's used for oncological indications. It measures genes, not proteins or other markers. It's prognostic and not diagnostic in nature, and it has a comparable cost structure. So therefore, we suggest to crosswalk our assay to the 81519 test. We're looking at messenger RNA, so the same material. We measure a slightly higher number of markers, 70 instead of 21. We use the same specimen type, FFPE. It's an algorithm that's prognostic, and so that concludes our recommendation to crosswalk this to this CPT code 81519 as an MAAA test that uses messenger RNA. Are there any questions?
So this is a new MAAA. You did not have a category or Appendix O code, tracking code before?
The code before was retired that we use.
Okay. So it was retired before or at the same time?
It was retired in 2016, if I'm not mistaken. So it was before we were issued a new code. Well, before we went through this procedure.
Okay.
Along those, Edith Hambrick, CMS, along those same lines, I'm confused what retired means. So did this particular code, 81519, what was the code that was retired a predecessor code that was exactly the same, or did someone withdraw or ask that their CPT code be discontinued and this is an entirely new code?
I gotta defer this question to Vicky Reyes,
Okay.
who was involved in that process.
All right, thanks. Then I have some more for you.
Yeah, sure.
The code that was currently retired was the S3854 code and was reinstated, but we were told that we needed to pursue a Category 1 code.
So it was an S code and not a CPT code?
It was an S code,
Okay.
S3854.
Okay, great. And did you have any public pricing on that one? If it's not public, tell me. All right. Okay, great. So now back to you guys. So I see that you have your comparison chart and you have several here that you thought could be codes that could be used. What is the defining characteristic? Because as you've noted here, is diagnostic versus prognostic something that you think the panel and CMS should consider? Does that make a difference in the pricing?
Yeah, I think I think all elements count, but to address your specific question, for a prognostic assay in our prospective randomized trial, we've included patients between 2007 and 2011 and then waited for 5 years on the outcome. So for a prognostic assay, to generate the data, the validation data, that tends to be more expensive than for a diagnostic assay for which you have the information instantly available.
Okay, so you're saying that when people publish information on the diagnostic, they don't have to wait that time period interface that you're talking about?
No, to know whether somebody has a disease or not, that answer is instantaneously available. To know whether the breast cancer is going to recur at 10 years, you have to wait for 10 years, or you have to find very well annotated cohorts of retrospective randomized trials with 10 years follow-up. So those tend to be far more difficult to find and more expensive to access. And also the prospective randomized trial following up with thousands of patients for 5 to 10 years, it tends to be very expensive.
Okay, and number two, this is just a general question for me because I don't know anything
Sure.
about these things. The genes, in the past, we've had people who say we should pay per gene or per locus or per something, and then some people came with some logarithmic scale and some people came with some other things. So, in your opinion, does the number of genes make a difference that you are querying based on whatever method that you're using now? I'm not going to ask you to postulate about all the different methods, but whatever method you use now, does the number of genes matter, or is it sort of like once you do one, and then the rest of them are discounted because you only did, you had to set the thing up? So, what do you think?
So, I think the clinical utility is where the value is. So in our case, we use the 70 genes, and what we've shown in our prospective randomized trial is that patients that were considered to get chemotherapy, but were MammaPrint low risk, if they did forgo chemotherapy, they had an excellent survival, and if they received chemotherapy, they had no survival benefit. So I think it's more the answer for the patient, how valuable is it? In our case, it's a high or a low risk and dichotomous answer. And I think what the trial showed is that 3 out of 4 can safely forgo chemotherapy. So I don't think it's so much about the number of genes as the value of the information.
Okay, and so just because I have you on the spot, there'll be others who come up after you. They'll ask this question, so don't feel bad. So how do you determine that wonderfulness of clinical utility? I mean, is it a percentage of how many don't, and you did a calculation and you figured out that, say, whoever that much money? Is it the R&D costs? And I'm basically, is it R&D? How do you come up with that in your mind, that clinical utility that's the add-on to, as you said, since the number of genes is not the important thing? How do you come up with that number?
So we've provided our total cost structure when we did our tech assessment with CMS in 2009, and so that came to the cost and the pricing that we have today, which is very much in line with the crosswork that we are proposing.
Central office, or was this MolDX, or you said?
MolDX,
okay.
Yes.
All right. Thank you.
Thank you.
Our next speaker is Matthew McCarty from Genotox Laboratories.
Good morning. My name is Dr. Matt McCarty. I'm a board-certified anesthesiologist and fellowship-trained in chronic intermittent pain. I'm in private practice in Austin, Texas. I'm also the CEO and founder of Genotox Labs, and I thank you today for allowing the opportunity to discuss our new code, which was awarded this past year. The test is commercialized currently as ToxProtect. It is a test that is designed to detect urine substitution, be it other human or synthetic urine. It involves a method of presumptive testing with definitive confirmation of positive results of any drug classes, as well as specimen verification matching the donor DNA to the sample and the urine, the DNA in the urine. A little bit of background, I think. How to cheat a drug test is one of the most common searches currently available on Google right now. 1.5 million results. Products including detox, additives, prosthetic devices, to blogs giving people instructions on how to cheat a drug test is fairly common. If you spend enough time on these blogs, you realize that the most common and foolproof method is the recommendation for synthetic or substitute urine in passing a drug test. When I came up with the idea to do this test in our lab 4 years ago in my practice, I was increasingly frustrated by patients I knew that were cheating my drug tests, and I thought substitute urine was playing a role. We did a cursory search of Amazon at the time, and there were approximately 80 products available at that time for synthetic urine. Just yesterday I looked, and there's now 280 synthetic urine products available for purchase So the problem is growing, probably parallels the legalization of marijuana in the states. But the bad part about this is these products and these techniques are finding their way into medication program, monitoring programs, and sobriety monitoring programs. Cheating drug tests not only represents healthcare fraud, it undermines the single best tool we have as clinicians for drug monitoring and sobriety monitoring. The current urine drug test validity measures are unable to detect warm substitute or synthetic urine. In our 18-month commercial experience currently performing DNA authentication for over 100 clients throughout the United States, we've done approximately 15,000 tests. 98% of the time when we have a negative match between the donor and the specimen, all validity tests were within the normal range. So it's clearly the current test is not up to the job of uncovering this particular problem. With more than 90 people a day dying of prescription drug overdose, and heroin included, it's incumbent that we need a more advanced monitoring tool at our disposal as clinicians. Just how practically I use this and how other clinicians use this in their practice, when confronted with a negative match, the practitioner can surely then discontinue controlled substances and also initiate discussions on why the cheating occurred. Usually they're using illicit substances, and we can then proceed them on to recovery or medication-assisted treatment. With positive matches, those are just as useful in that they allow the clinician who's under increasing pressure right now to not prescribe controlled substances for pain a reason to continue prescribing if doubts arise about the authenticity, rather, of the urine sample. So the purpose, again, is to authenticate drug test samples to a specific person and catch sample substitution. And we found that this gives the earliest possible detection of misuse, abuse, or relapse, and is appropriate for use in high-risk patients and all unexplained aberrancies on urine tests. The methods include three aspects: sample authentication with multiple modalities, including DNA authentication with SNP matching, as well as a synthetic urine detection technique using principal components of key physical properties in human urine. Additionally, we do qualitative presumptive screening and then a quantitative definitive screening looking for actual levels of drugs and their metabolites. Cost of the test. When we enroll a patient into our Tox Protect program, you're usually obtaining 2 DNA samples, one buccal swab, and you're obtaining DNA out of the urine. Getting DNA out of the urine can be fairly difficult, and that's what took us the most time to develop the technique to be able to get a 95% call rate. So it's a little more expensive than just half of the $250. Presumptive screen cost us $45, quantitative confirmation $90. Anticipated charges are $16.50. Our recommendation is to do a blended crosswalk of 3 codes. The first code is well known. It's the current 80307 presumptive code, for which we use LCMS using library matching in our clinic, as well as the definitive code G0480, which confirms up to 7 drug classes and or metabolites. The third code was suggested to us by the AMA coding committee as a likely code to use, in that it is the chimerism code 81265. The similarities between this code and the work that's done and what we do are very close in that both use a comparative analysis. Ours using SNPs, they used short tandem repeat markers, and we actually buccal swab the patient and then test the comparative specimen. In this case, it is a cup of urine to determine if the DNA is a match in the absence of chimerism. What we put forth as a rationale for our pricing is a blended rate of these codes. The 81265 we suggest should be 100% funded, but the subsequent codes, because there are 3 tests done on the same sample with the same collection person, the same postage and handling within our lab, should be at 50%. We think the G480 is reasonable because this test is going to be intended for high-risk patients and for patients where there's unexplained aberrancies, both from the patient and the physician, giving us a total value of $393.72. So that's all I had. If there are any questions.
So I'm interested in your selection of 81265, which seems to imply that there are different people being tested as opposed to the same person being tested. So I just wanted to know if, given that that code appears to talk about that, are you feeling that it's, for your testing, it's sort of like blind and technically the test can't tell, therefore it's an appropriate code? It seems like that might not be the right code.
Well, we chose this code on, again, suggestion of the AMA and thought about it further. And there is, admittedly not the donor is, you're testing really the same person's DNA in both. You would need to know the actual person submitting the fake urine to be able to know whether or not their DNA was present in the urine. And this was about the closest code that we thought involved the same amount of work, same amount of doing the initial buccal swab, DNA, PCR testing, and then doing the extra work of extracting the DNA from the urine. As compared in this code, it's usually from tissue, which is easier to get DNA from than in urine. So it was a difficult decision whether or not to use. There was not a code that did a chimerism of two different matrices we saw, so we chose this.
Thanks.
Did Brian Yang make it? Okay, thank you. Our next speaker is Brian Yang from Thermo Fisher Scientific.
Thank you for the opportunity to present. I will be discussing, this advances. Oh, there we go, sorry, I'm the wrong button. On 8600X, this is the new CPT code for component-specific IG testing in the literature. It is also referred to as component-resolved diagnostics or molecular allergy testing. And we are requesting a crosswalk of 5X of 86003, which is the code for whole allergen-specific IG testing. And the crosswalk comes out to a request of $35. All right, just to give you a little bit of background on allergy, traditionally there are two ways, or there have been two ways of doing allergy testing. One is through skin testing, and the other through in vitro methods. And these generally have used or have traditionally used crude whole allergen extracts to detect if there's some sort of sensitization to an allergen source. Today we have much more evolved in vitro test methods in component-resolved diagnostics that have significantly higher specificity, which are able to distinguish sensitizations due to antigen cross-reactivity. So essentially, really to kind of cut through some of the noise that we see in whole allergen extract-based tests. And these component tests are typically manufactured through recombinant DNA methods, and in some cases, we use advanced purification techniques. All right, so the purpose of allergy testing in general, they're really used as confirmatory tests. This goes for both extract-based and component tests. And so with extract-based tests, I'll have a figure coming up in the next slide, but with extract-based tests, you are measuring sensitization to really a cocktail or heterogeneous mixture of both allergenic and non-allergenic materials. So an individual may be sensitized to one or many of the molecules found in these heterogeneous cocktails of molecules. The difference with component testing is that we are actually measuring specific IgE sensitization to each of the individual component molecules found within allergen extracts. And the value that component testing really provides is that, one, we can, in many cases, be able to distinguish between genuine sensitizations to a particular allergen component and sensitizations that may not be clinically relevant but are due to cross-reactivity. They can also be used and have been used to really assess varying degrees of risk for clinical reaction, particularly with peanut allergy. And so here's the figure that I had sort of alluded to, really to kind of give you a visual of the difference between extract-based tests and component tests. So, you would identify a source material, and in this case we have a diagram of peanut. With extract-based tests, we're making an extract of the peanut, and we're measuring sensitization to all of the different molecules that we've extracted from the peanut. This can tell you that there is some sensitization, but what can be misleading sometimes about extract-based tests is that, or maybe give you an incomplete picture, is it doesn't tell you the severity of the reaction or if it's actually a genuine reaction. So this is where allergen component testing is really provided significant breakthrough in allergy diagnostics. And so we test for each of the individual molecules found within an allergen extract, and each of these molecules have different sort of characteristics in terms of what they mean clinically. So you'll have storage proteins like ARA-H1, 2, and 3, which are typically more clinically significant in patients with severe or systemic reactions to peanut. Whereas the ARA-H9 and ARA-H8 proteins are typically associated with cross-reactivity to peanut, and in many cases, the types of symptoms you would observe are those with local reactions that are generally not as severe as those you would see in sensitization to storage proteins. So the test method, it's basically done with samples of human serum or plasma. The antigens are bound to a cellulose solid phase, and won't read through all the bullet points, but essentially we measure fluorescence from that. Okay, so now I want to discuss really, the difference in manufacturing of these tests and why they're so different. Whole allergen crude extract tests are fairly straightforward and simple to produce and relatively much less expensive. For one, there is no preclinical work, discovery, or initial evaluation when it comes to whole allergen extracts. You basically identify an allergen source, whether it be peanut or birch pollen, and you extract it, you put it on a solid phase, and then you're basically ready to go. Components, whole nother ball of wax. It takes about 2 years on average for us to go through discovery and initial evaluation, so preclinical work and validation to develop each component. And then the production is much more involved. I mentioned before that most of our components are manufactured through recombinant DNA methods and advanced purification. These manufacturing time is also significantly longer. With extract tests, we're talking about a month, whereas with component tests, about 10 months. And then the third difference that I'll point out is with intellectual property and licensing fees. So for many of the component tests that we develop, we have to license the IP, and oftentimes that can be up to 4 times the production cost. So there is a significant difference in the cost of developing and manufacturing, bringing to market a component test than the relatively more simple and straightforward whole allergen crude tests. Here we just wanted to put up our list prices that we have for our whole allergen tests as well as our component tests. So our whole allergen tests are sort of separated into 2 categories. There are routine whole allergens, and then there's esoteric whole allergens. They're pretty comparable in price, but there is a bit of a difference. $525 for the routine and $590 for the esoteric. And then our component tests, excuse me, they range from anywhere from $18.50 all the way up to $50, but really, on average, they are somewhere around about $46 per test. Okay, so just to conclude here, our recommendation for our crosswalk to 86003 is based on really the significant differences in the development and manufacturing and cost of the component test kits. I went through that in the table in the previous slide. Also, when you're looking at the difference between 8600X and 860003, like I said, the differences in the kit cost, really the method of actually running the assays are the same, but the differences in the cost of developing the kits. Kit cost ranges, again, $18.50, $50 with an average of $46.25. We have different, pricing depending on the lab partner, depending on size of the lab, how much they're running, et cetera. So we believe really a weighted average, considering our national test volume, fair market discounts for what we provide our lab partners, depending on what they run, would be about 5x of 86003. Any questions? Yes.
So I have one question. So you're recommending the crosswalk purely based on the value of the reimbursement or the cost of it, the actual work involved. Is that 5 times what you're of what's involved with it, or is that purely based on a cost?
It's based on the cost of of manufacturing the tests and all the R&D, the discovery and preclinical. Like I mentioned before, with whole allergen tests, it's pretty straightforward. There is no preclinical or R&D discovery work. You have an allergen source and you make an extract and you put it on a solid phase. With component tests, much more involved. You have to go through a discovery phase. There's clinical validation. That can take up to 2 years per component on average, whereas there is absolutely zero preclinical work for whole allergen tests. And then the manufacturing methods are completely different. So we are going through much more costly recombinant DNA methods for manufacturing our component tests than our whole allergen tests. And then thirdly, we don't actually necessarily own all the IP for every single component that we manufacture, so there are licensing fees for that involved as well.
So if this is the manufacturing cost of the test, what would it cost the lab to run it?
The cost for the lab to run it is really, in terms of the labor, is that what you're, okay, so the labor is no different than 86003. It's just the cost of the kit is much higher. Yes.
Karen Nakano, CMS. Quick series of questions for you. So in reviewing some of the other presentations, we noted that there appears to be a few differing opinions on what this code should be crosswalked to. So my first question is regarding the code 86157. I don't know if you'll have time to look that up. We would like to know why some of the other folks feel that 86157 is a more appropriate crosswalk. Also, some of the other presenters have indicated that they feel 86003 should have a multiple of 1 and not 5, and not 5. So we would like to hear your opinion on that.
Okay, so I'm actually not familiar with 86157, so I'll probably have to follow up with you on a response to that. But as far as 86003, basically, are you asking, other presenters have suggested an equivalent, basically?
Yes, in reviewing the other presentations, we noted this, that 3 different recommendations were made for this code, yours and 2 other of the presenters. So we're just trying to sort out what your thoughts are on why.
Yeah, so as far as the doing a 1x to 86003, I guess I would respectfully disagree with that opinion. As I mentioned during the presentation, I'd say really there is a significant cost difference in how we manufacture these tests. In fact, we have a limited number of components that we currently have introduced to the U.S. Roughly about 50 or so have been cleared through FDA, but actually not all 50 are offered through labs because of their cost structures. And then we have probably another 50 or 60 components that are available in Europe, but are not available at all in the U.S., once again, because of the high manufacturing costs. We would just simply lose money in having a crosswalk of 1x of 86003. So we could not viably actually bring those tests to the U.S. And so that is actually, I would say that is also probably true of the state of current component tests, is that we brought them to the market with the thought that eventually we will get a new CPT code and a more appropriate reimbursement rate. It's not sustainable for us to continue to offer these tests with a crosswalk of 86003.
Okay, thank you.
Yes.
Just curious, why this particular multiplier of 5x? Why not 4x or 6x or some other number?
Yeah, so it's based on a composite of what our list price has been, and then also what we also offer it to our lab partners, as well as our manufacturing costs. So it's a combination of those three variables. And really 5x was, in our estimation, really the most appropriate multiple that would make sense. There are some other labs that offer component tests as a laboratory developed tests, and if you want to call them street prices, they don't offer any discounts. If you want to, a great example is a marker called alpha-gal. It's used in measuring. It's really the only way to determine if you have a allergy to meat, to red meat allergy. And so you develop, it's an interesting story where if you get bitten by a tick and you actually become sensitized to red meat. There are no discounts for that test. $35 is actually, $37 actually, is, I believe, what is offered as an LDT. And so that falls in line actually very closely to what our 5X estimate was. Yep. Yes.
I'm sorry, one last question. Does Thermo Fisher anticipate the cost of this test to increase as the number of individual components increase?
So as we, in other words, as we expand our catalog, we don't expect it to increase, no.
Okay, thank you.
Okay, at this time, let's take a 15-minute break. If you need to stretch your legs, get coffee, the cafeteria is downstairs. And we will start up again at 10:45. Thank you.
And I'll send it out, yeah.
Right, no, I know, but the the PowerPoint presentation. Well, yeah, I think John sent them last time. So is there a way of doing that?
I'm just letting you know. I can't guarantee it, but I'll have to wait and see. Okay, that's fine. I'm just letting you know. So I'm keeping a spreadsheet of all those things and all those questions, and we're looking them up as we go.
Whatever they sent, they sent it to you. If they send it So the transcription I can't come to, they're through contract, so that's not possible.
Then, where's Chuck? Can we ask Chuck? Knows about the closed captioning?
No, exactly. I would think the AV comes from that.
Can we find out?
When you say to give the closed captioning, are you saying to
so
give the transcription?
Yes. Yes.
You want to know
or another way that, yes. Yes.
Give it to them and they can use that in their...
Yes. Okay. Yes. Or at least have us post it, right? Because we say we're going to post it.
We don't post it.
Then they can use that. That's what Val is saying.
So I CC'd you on the email with Chuck. So,
I'm tempted to walk my sorry little butt around the corner.
Over to the AD people.
Chuck. How much time do I have?
10:45. So you're about 9 minutes. I'll go to the back to see if
you go here. I'm going to go to Chuck.
Okay.
I'm going to back that way.
Okay.
Okay, if folks could venture back to their seats, we're going to start up again. Thank you. Our next speaker is Paul Rudensky from McDermott Plus Consulting, Alere, and Hologic.
Good morning. Nice to talk with everyone this morning. I'm presenting this morning three molecular biology codes for crosswalk on behalf of Alere and Hologic. Two of the tests are Alere's, one is Hologic's that I will explain. So, and I know that when we deal with these new codes, it's a little bit hard because the numbers are so close to each other. The 876XX is infectious agent detection by nucleic acid, RSV amplified probe. Then we have 87X6X, which is infectious agent detection by nucleic acid, Zika virus amplified probe, and then the 86X7X Zika virus IgM. So three codes, two are Zika related and one is RSV. The RSV amplified probe and Zika IgM are Alere tests, although there are other manufacturers, and the Zika virus amplified probe is a Hologic test, although again there are others that have those tests. So first with 876XX, which is the RSV amplified probe test. This is a standalone RSV amplified probe test. There are current respiratory panel codes that have pricing that are for multiple organisms that include RSV, but there are times where docs have a pretty good sense of what they're looking for and really don't need to do the multiple panel. So this was developed as a standalone test for RSV as an amplified probe technique and received a code for next year. It is for qualitative detection of RSV. It can be in nasopharyngeal swabs, either eluted and transformed media or directly. It's intended for diagnosis of RSV in children under 18 years and in older adults, although now, given the fact that I'm over 60, I'm not quite sure if that's older adults, with clinical and epidemiologic risk factors. It's an isothermal nucleic acid test. It does look for both RSV-A and RSV-B and reports out as a positive or negative. So it's a multiplex for both types of RSV, but reporting out a positive or negative for either. So if either A or B are present, it reports positive. If neither are present, it reports negative. Our recommendation is a crosswalk to 87801, which is infectious agent detection by nucleic acid multiple organisms amplified probe technique. So that is the multiplex where you have multiple organisms and report out a single result. Shows the 2017 NLA. That is the code under which this is currently reported. This is a CLIA-waived test, or at least the Alere IRSV test is a CLIA-waived test, and as you may be familiar, when you have CLIA-waived tests, CMS issues a transmittal indicating what the current coding is, and that does identify 87801 as the appropriate current code for this test. So the second code is the 87X6X, which is the Zika amplified probe test. This here comes from the Aptima version. This is an emergency use authorization test, as is the next one. On the FDA website, you'll see that there are several different amplified probes that have been approved as EUAs by the FDA. That is not the same as a regular FDA approval. This is intended for qualitative detection of RNA from Zika virus in serum, plasma, or processed urine from individuals meeting the Zika virus selection criteria of the CDC or epidemiologic criteria. And as some of you may know, the CDC just recently changed the criteria. So in looking at women, instead of a single exposure, they're looking for more a prolonged exposure for women at risk. Again, it's under the emergency use authorization pathway and is a transcription-mediated amplification test. Our recommendation is to 87502, which is infectious agent detection by nucleic acid influenza virus for multiple types or subtypes, including reverse transcription and a multiplex amplified probe technique, first two types. The basis for that is on the resources, the cost-based rationale. We did kind of a cost of goods type of analysis here. The supply cost is $32 per test. You need to run, and this is consistent with the package insert, in order to be able to get the curve appropriate, you need to run 6 calibrator controls per batch. And we consider that batches across different types of labs run about 3 to 10 patient reportable results per batch, so that we took 7 as a midpoint there. And so that means that you would need 13 tests to produce the 7 results. And that, just looking at the kit alone, gets you to $40. When you add in some of the labor costs, which is about 5.5 minutes for a tech, and you look at the equipment cost, this is run on the Panther system, which is $100,000, and using the same methodology that we use for the physician fee schedule and looking at equipment and for anatomic path tests gives a total for the direct cost of about $70, and then in the physician fee schedule for independent lab, the direct to indirect is $63.37. So that gives a total cost of about $108. So that there are methodologic similarities because it's an amplified probe test, and then there are cost similarities. One of the things I would also say, and something that I think is critically important both with this test and the next test, is that For emergency use authorization tests, you have both manufacturers and laboratories coming up and responding to an emergency. So when you have from a manufacturer side to pick up a test like this, you often are setting aside something else that you otherwise have in development to bring something like this in. There are substantial costs to be able to do something like that relatively quickly, so you're going to have that reflected in the kit cost. In addition, on the laboratory side, there are very specific reporting requirements as an emergency use authorization that aren't consistent with what a lab otherwise would have to do for other tests. These tests are not at the same status as something that is cleared under a 510K by the FDA or a PMA. So the laboratory actually does have to do additional validation steps when they bring these into the laboratory, and they have to be reporting results out for public health purposes. So there are additional costs that are incurred both on the manufacturer as well as on the laboratory, and it's critically important that we get things like this right, because I can tell you from some other experiences we've had where folks come to the fore for emergencies and CMS has not been able to meet that in terms of recognizing the emergency costs, they're left with a provider holding the bag for that. And this is something that we've had discussions with the Assistant Secretary's office about trying to come up with ways to make sure that we are appropriately recognizing when people are responding to emergency threats. Again, similar overhead costs, as we mentioned before, to the 87502 and the total costs. What I had here was just based on the supply costs. What I said orally actually added in some equipment and supply costs to get it up to $108. The last is 86X7X, which is the Zika virus IgM. This is for, as you probably know, that depending upon the timing of the test, you can run an IgM test or you can run a amplified probe test under the CDC guidelines. The recommendation here is to 86536. This is based on a resource crosswalk, not so much a quantitative or a crosswalk based upon methods, because there really wasn't an IgM test that we could find that was within this range. But we feel that it is consistent with the resources required. The estimated kit price is about $40, and then, which is again because of the requirements to develop an EUA kit and the costs that are on the laboratory to furnish a kit like this. And that's it. Any questions?
On the RSV test, does that report out both A and B separately, or just detects separately?
No, it detects separately and reports out just positive or negative. So if either A or B are positive, it reports positive. If neither are positive, it reports a negative. And that's consistent with the underlying 87801, how that's reported or used. Yeah.
On the Zika test, why did you choose 87502 as opposed to 87501?
Right. Because when we looked at the cost analysis, and as I said, and we'll supplement in our comments the more complete cost analysis because we didn't have it all completed at the time we submitted the slides, you really do have very substantial costs to run this assay. As I mentioned, you have the 6 controls that have to be run per batch, and that gets you to about $60 just for the reagent cost. And then when you add supply and equipment, you're getting into $70 plus just for the cost of goods, and then factoring in overhead, whereas the 87501 would be at that level without factoring in any overhead at all, without considering the fact that the labs do have to do more with an EUA than you otherwise would have to do with an influenza single test. All right. Thank you all.
Our next speaker is Kevin Trainer from Immucor.
Good morning, and thank you for the opportunity to speak today.
My name is Kevin Trainer. I'm an employee of Immucor, the manufacturer of the precise type HEA test that I'll be speaking to you about today. Effective July 2014, the precise type HEA test was covered under MOPATH Tier 2 code 81403 with the specific descriptor HEA used to identify this test from about 40 other tests covered under that code. We applied for and received a PLA code, code 001U, which was effective in February of this year. That code was not available at the time of our original application. And the precise type HEA test is a 35 antigen panel test that seems to better fit with the description of a PLA code rather than the more generic MOPATH CPT codes. And during this time, there's been no substantial change to our product or its costs. Precise type HEA is the first and only FDA-approved molecular test for human erythrocyte antigen testing or red blood cell antigen testing, and we received our FDA approval in May of 2014. The test tests for 35 antigens from 11 different blood groups, as you see pictured on the table on the screen. And providers order this test to help prevent alloimmunization in chronically transfused patients, as well as to help mitigate the serologic interference that can exist in recently transfused patients, among other purposes. There are only 18 FDA-approved antisera to test for the 35 antigens covered under this panel, which provides the only way to test for these other antigens that don't have an antisera equivalent. And it also helps illustrate some of the difficulties in comparing the precise type HEA test to its serologic alternative, as we're offering test results that were historically not available. It's also worth noting that of the 18 approved antisera, only 5 are approved for use on automated analyzers, which does limit throughput for high-volume testing. I do want to give a brief overview of the technology and how it operates. And so the test utilizes our proprietary bead chip platform and is run using our own instrument, our AIS, or Automated Imaging System. And that's accompanied by our software that has a proprietary algorithm to take a fluorescent value and interpret that for a genotype and then corresponding predicted phenotype. So the process at a high level is that we take DNA extraction from whole blood and perform a single multiplex PCR reaction. That sample then goes through 2 enzymatic digestion steps before it is applied to the surface of our bead chip. The bead chip is a small silicon wafer with about 4,000 beads contained in it, each coated with a specific single-stranded DNA probe that's specific for the target markers of interest. Once that sample is applied to the surface of the bead chip, elongation occurs, incorporating a fluorescent dye. And then our instrument is able to then identify that dye, and our software can then interpret that to a result. All MolDX jurisdictions and CABA specifically state Immucor's precise type HEA test in their coverage policies under code 81403. 6 of those 8 MACs have finalized local coverage determinations for the PLA code 001U, while a few have not yet updated their coverage policies for that determination. The document numbers for these policies are included above for your convenience. The 2 MACs that do not have a coverage policy specific for precise type HEA have been provided all of the same information, but have yet to publish a policy of their own. So our recommendation to the panel is to crosswalk code 001U to the CPT code 81403 with the specific descriptor HEA. The 001U code mimics the current 81403 code with the descriptor HEA in a unique and proprietary manner, as I've explained today. And it also represents the first and only FDA-approved product to perform this task. We further recommend to limit that crosswalk process to the MACs that have a finalized local coverage determination specific for this test prior to February of 2017. As you can see those listed below. The purpose for that is that these are the ones that have had a history with the test who would have the necessary data to look back retrospectively and find the appropriate payment rate for the new code 001U. Thank you.
So you're recommending a crosswalk to the Tier 2 MOPATH code 81403. There's no NLA associated with that, so you're asking for a zero reimbursement crosswalk?
There is an amount associated with that. So for that code 81403 with the descriptor HEA, there is an approved amount. It hasn't been published, so it's not public, but I could share some anecdotal.
So the public CLFS, there is no reimbursement value for 81403, and you're asking for a crosswalk to 81403.
From everything I've seen, we've been getting reimbursement, or our customers have been receiving reimbursement on 81403 in the specific MACs that have those published policies with the policy numbers listed, on the previous slide.
But can we crosswalk to local amounts? I think we had this discussion last year, actually.
Well, the recommendation was to identify the specific descriptor because the test under 81403 varies significantly in complexity and cost, and we do want to make sure that it's not generically being directed to 81403 without the specific acknowledgement of that test.
Right. No, but this was an administrative question, I think, to CMS, is can we do a crosswalk to a locally determined amount if it's not on the national fee schedule?
I believe that code is currently under the Gapfill process. Okay. And once we get a price, then it'll be effective. But at this time, we don't have anything because it's under the Gapfill process.
So I think last year what we did was, if it was under Gapfill, we had to recommend Gapfill again, because otherwise the price would be zero, is what it is right now.
That could be a recommendation for the new one, yes. That could be.
Just you said 81403 is maybe in your written comments as a follow-up, depending on what happens at the meeting. You may want to submit a different code number if it turns out that either it's, unless you're comfortable with Gapfill, of course.
Well, we could see what the gap fill is for that and then reassess.
Okay.
I think you may have answered this, but for those contractors, those MACs who have LCDs, are there other payment methodologies that they've used other than using 81403?
They are in the MolDX program, so they've used Z codes through McKesson, but otherwise it would just be.
And is there a payment methodology that they've used? Has anyone tried to use crosswalk or some?
Not that I'm aware of
Or
yet.
other code?
Not that I'm aware of.
Thank you.
Hi, this is Karen again. Quick question for you. In the unlikely possibility that you do not, that we cannot use the 81403, your recommended crosswalk, it would be great if you could let us know quickly before deliberations begin if there is another crosswalk that you would recommend.
Okay.
Okay, our next speaker is John Warren from McDermott Plus Consulting, 21st Century Coalition.
Okay, good morning, everybody. Thank you for the opportunity to present today. My name is John Warren. I'm the Senior Director at McDermott Plus Consulting, and I'm here today representing the Coalition for 21st Century Medicine. You can see the members of the coalition on the slide that's behind you. The coalition represents a group of innovative diagnostic technology companies combined with clinical labs, researchers, physicians, and venture capitalists, all linked by the common mission of developing and commercializing state-of-the-art diagnostics that improve patient health. The coalition appreciates the opportunity to present today and provide our input on the CY 2018 CLFS fee schedule, the public meeting, and tomorrow's advisory panel process. We'll be presenting 3 recommendations today. In summary, the first recommendation for new code 81X41 is to crosswalk to existing code 81519. Our second recommendation to crosswalk or to gap fill new code 815X1. And our third recommendation for new code 0003U is to crosswalk that code to 1.25 times 81539. In general, the coalition believes that either crosswalking or gap filling can be appropriately used to price new or substantially modified MA codes. Ultimately, the decision to crosswalk or gap fill rests on whether or not a substantially similar MA test code exists compared to the new or the revised test code. We believe now, more so than in previous years, that there are some nationally priced MA test codes that exist and can and should be appropriately used as crosswalks for new or revised codes. However, in other cases, there still may be no appropriate analog code in the MA category or any others that can be used, and in those opportunities, the choice to gap fill is the correct one. The first code I'd like to talk about is new code 81X41. The code descriptor is oncology, prostate, mRNA gene expression profiling by real-time RT-PCR of 46 genes, 31 content, 15 housekeeping, utilizing formalin-fixed, paraffin-embedded tissue. The algorithm reported as a disease-specific mortality risk score. This new code describes the Polaris test that was developed by Myriad Genetic Laboratories, a coalition member. The Polaris test is a prognostic test which directly measures tumor cell growth characteristics for stratifying the risk of disease progression in prostate cancer patients. It's a messenger RNA expression analysis using RT-PCR on a formalin-fixed, paraffin-embedded tumor tissue sample along with a proprietary algorithm. The Polaris test combines the RNA expression levels of 46 genes, as I mentioned, 31 involved in cell cycle progression, and 15 housekeeping genes to generate what's called the Polaris score. The Polaris score is used to determine the aggressiveness of an individual patient's cancer. This risk score information is new and independent of standard clinical pathological features such as PSA or Gleason score. As I mentioned, the coalition recommends a crosswalk to existing code 81519. This code is commonly used to report the Oncotype DX breast cancer assay. It is a MA code that describes a test using the same sample type and methodology as the Polaris test, and it produces the same type of prognostic risk score. The Polaris test measures 46 genes, whereas 81519 evaluates 21. This recommended crosswalk would result in a payment rate based on 2017 NLA information of $3,443. The next code I'd like to discuss is new code 815X1. The descriptor for this code is oncology prostate, promoter methylation profiling by real-time PCR of 3 genes, GSTP1, APC, and RASSF1. It also uses a formalin-fixed paraffin-embedded tissue and an algorithm that reports the likelihood of prostate cancer detection on repeat biopsy. This new code describes the Confirm MDX for prostate cancer that was developed by MDX Health, a coalition member, and we heard from them earlier today. The Confirm MDX test uses a methylation-specific PCR analysis of FFPE prostate biopsy tissue that was collected during the preceding 24 months. For men who received the negative biopsy results within those 24 months, the Confirm MDX for prostate cancer can be used to address concerns about false negative biopsies by either ruling out men who had a previous negative biopsy, by confirming that no cancer actually exists, or by ruling in men who had negative biopsy results, but for whom, in fact, harbor undetected small tumors that were missed during the needle biopsy. As mentioned earlier today, the coalition supports the recommendation that CMS allow contractors to gap fill this price for the next year. In the case of the Confirm MDX for prostate cancer, there are no appropriate analogs on the CLFS, either in Tier 1, Tier 2, GSP, or the MAS, and the Confirm MDX for prostate cancer involves a methylation-specific PCR technology along with an algorithm, the combination of which is unlike any existing code. As a result, as I mentioned, the coalition believes that in this case, gap filling is the most appropriate method to use to set payment rates for this new code. And the third and final code that I'd like to discuss today is new code 0003U. The descriptor for this code is oncology ovarian biochemical assays of 5 proteins. I won't pretend to be able to pronounce them appropriately, but they utilize a serum and an algorithm reported as a likelihood score. This new code describes the Overa test, which was developed by Aspira Labs, a subsidiary of Coalition member Vermilion Incorporated. The Overa test is an FDA-approved blood test that uses 5 markers, also in combination with an algorithm, to produce a numerical result that represents the risk of cancer. Overa is the next generation of the OVA1 test and is intended to be used to help predict the likelihood of cancer in women with ovarian masses and is intended to be used as part of the preoperative evaluation. The coalition recommends a crosswalk to 1.25 times 81539. This would result in a rate using 2017 NLAs of $752. The coalition feels that the resources required to perform the Overa test are similar to those required to perform the 4K prostate test described as 81539. Both tests use a biochemical assay of serum to produce a prognostic likelihood score. However, we note that Overa evaluates 5 biomarkers compared to the 4 measured by the 4K score, thus warranting the 25% multiplier. Thank you.
So why are you not so if this is for 0003U, which was essentially it's OVA1 version 2, why are you not recommending crosswalking it to OVA1?
That's a great question. We looked at the resources that go into performing this new test to see what was close and available in the existing CLFS. And we believe that actually the resources that go into 81539 are very similar to those required for the new test, so that's what we used. Certainly we'll be able to, and more than welcome to provide more information on that in our written comments.
Hi, Edith Hambrick, CMS. So I'll ask you the same question I asked the gentleman about his genes. I'm asking about your proteins. So do you believe there's a direct correlation between the number of proteins, in this case, that you're analyzing and how the payment rate should be?
Right, no, I mean, great question and perfectly legitimate question. And I think the number of biomarkers, whether they be proteins or genes or whatever, are certainly a factor that goes into valuing any test. But there's many other things that go into the valuation of the test, in addition to the number of biomarkers that are being measured, the use of the test, the output of the test, sort of the process and the resources that go into the test. All of those things together are what's used to appropriately value the test. But yes, certainly the number of biomarkers is one of those metrics.
So in this case, you seem to be having a one-to-one sort of correlation, 5 to 4, but you're saying in the future that may not, in this particular test, you're making the argument that it should be, but for future tests, that might not be the case.
Or it may be the case. I can't speculate on what a future test may or may not look like, but certainly if it is appropriate to consider the number of biomarkers, that would be the appropriate thing to do.
Well, everybody usually, considers the number. I'm just trying to get whether it's 1 to 1 or 1 to 2 or logarithmic. And again, as I said before, some people came before us and they didn't have a sort of 1 to 1-ish. They had various other methods.
Absolutely.
Thanks.
Can you give us a little bit more on why you did not choose OVA1 versus using 81539? I'm just curious. You've chosen a multiplier for this. Wouldn't it have been equally rational to choose a multiplier to OVA1, or is there something distinctly different about the resources?
So if I can defer your question, my colleagues will be speaking in more detail about this test later this afternoon. We can or perhaps even this morning. I'm sure they'd be happy to answer that question in more detail for you. But we can certainly make sure that we provide that information in our written comments. Okay.
So OVA1's not priced, so I don't know if it's out for Gapfill. It's not on the fee schedule.
Okay. Well, certainly material information, but, you know, it, then I'll then in turn say, okay, so how did you arrive at the 0.25? Was that solely a multiplier established on the additional protein that you were assaying, or was there something more material that you would have this panel know in our discussions?
Right, thank you. No, it was a scalar based on the additional protein, and again, when my colleagues speak this afternoon, or later today, they'll certainly, I'm sure, be able to fill you in more on that.
Okay.
Okay, thank you.
So for the 81X51, is that a methylation analysis, or is it, did I see that?
The 81X51, excuse me?
Yeah, is that
Yes,
based
it
on
is.
a methylation analysis like Septin9 or something like that?
Can I get back to you on that because I don't have
Okay.
that information in front of me? Thank you. Okay. Okay, thank you.
Our next speaker is Greg Hamilton from Epigenomics.
Good morning. I'm Greg Hamilton, CEO of Epigenomics. Today we are here for the reconsideration request of CPT code 81327, Septin9, and its newly modified descriptor, promoter methylation analysis, to be crosswalked to 81288. CPT code 81327 is utilized for epiprocolon, the first and only FDA PMA-approved blood test for colorectal cancer screening. This new innovative test represents the advancement of new technologies as the first blood test or liquid biopsy for cancer screening. The FDA recognized the breakthrough technology utilized by epiprocolon, which tests for methylated Septin9 promoter DNA from whole blood, by granting priority review status because it is the first of a kind device to utilize circulating cell-free DNA for CRC screening. Epiprocolon represents the advent of liquid biopsy for cancer screening. The intended use of this innovative test is for average risk patients 50 to 75 years old who have been offered and are non-compliant with previously established methods such as colonoscopy and FIT. As with other non-invasive tests, a positive result is referred to colonoscopy. The target population who meet this criteria are known as the unscreened. The unscreened in the U.S. represent approximately 35% of age-eligible population, or about 25 million patients. It is these patients, the unscreened, who are among the most vulnerable to the disease, as approximately 43% of all CRC cases come from this group. With this new innovative test, we can now reach these patients and prevent late-stage diagnosis, assuming this new test is crosswalked appropriately for clinical adoption. During the 2016 crosswalk process, the analysis by the expert panel in this room overwhelmingly supported a crosswalk to 81288, with 9 votes for 81288, 3 votes for Gapfill, and 0 votes for 81287. Additionally, all the comments from the professional societies supported either 81288 or Gapfill. Again, 0 recommendations for 81287. These crosswalk recommendations from CMS's own expert panel and industry were consistent with the pricing of 81528, the most recently priced promoter methylation analysis for CRC. There seems to have been some confusion with the CPT code descriptors, as CMS's 2016 final decision crosswalked the test to 81287, despite the overwhelming support for 81288, and consistency for CMS's final determination for 81528. CMS's rationale for 81287 was 1, 81288 includes promoter methylation analysis in the descriptor, while 81327 mimics 81287 by including methylation analysis in the descriptor. And 2, the tissue type studied in these tests is not relevant to the resources required. As we look at the expert panel's recommendation from last year, their conclusions and recommendations just make sense. The expert panel recognized that both 81327 and 81288 are both methylation analysis in the promoter region, i.e. promoter methylation. Thus, they did not utilize the descriptor to crosswalk the test, but rather the resources required to perform the test. To that end, the type of tissue or sample, like dramatically more challenging requirements of circulating cell-free DNA, are clearly relevant to the resources required. The technologies employed, volume and type of reagents, and labor are clearly relevant to the appropriate crosswalk. The panel's recommendation clearly documents the appropriateness of 81288 as the correct crosswalk based upon the resources required. Plus, it significantly aligns with the methylation crosswalk component of 81528 to 81315. While we recognize the confusion of the descriptors, this issue has now been addressed. The AMA CPT editorial panel has harmonized the promoter terms, thus making the descriptor irrelevant as a rationale for crosswalking 81327. This clarity through the harmonization of descriptors allows CMS to now utilize the resources required, just as the expert panel did, as the main rationale for the appropriate crosswalk. In addition to the 2016 rationale for 81287 no longer being relevant, there are other significant reasons why 81287 is not an appropriate crosswalk. 81287 does not appropriately value the PMA status of the test, the over $30 million of investment in the PMA approval, recognition of the dramatically more challenging requirements of circulating cell-free DNA, the GMP requirements of the product, and the original acquisition, accessioning, and handling of the sample. Clearly, there is a myriad of reasons why 81287 is not an appropriate crosswalk. Whereas there are multiple reasons why 81288 is the correct crosswalk. The goal of the crosswalk process is to determine a new clinical diagnostic laboratory test that is comparable to an existing code, multiple codes, or portion of codes. 81288 is the best option for 81327 based upon the comparison of technologies, resource utilization, disease indication, and valuation and costs. This table compares 5 tests in rows across 8 features in the columns. When we look at all the relevant test codes across these features, what we see is 81235, 81528, and 81288 all have multiple characteristics that are similar to 81327, such as the resources required to execute large sample volume extraction and the qPCR requirements approaching 0.01% or single copy detection. What is also evident from this table is that 81287 is clearly the least similar of these codes. In fact, when you look at sample extraction technology, you can see the differences in valuation dealing with the dramatically more challenging requirements of circulating cell-free DNA. 81235, also a PMA test, utilizes circulating cell-free DNA technology on 10 mLs of blood with back-end qPCR, just as 81327 does. But 81235 is valued at $331.82. When you compare the valuations of circulating cell-free DNA, you see that the crosswalking 81327 to 81288 still probably undervalues the test when compared to other tests utilizing the same technologies. That said, the promoter methylation tests that most closely mimic 81327 are all priced in the 140 to 160 range. These data points demonstrate consistency with the resources required and the previous determinations by CMS. In the end, the resources required matter, and they justify a valuation in the $160 range, and clearly the valuation of 81287 is inadequate and inappropriate. As discussed, the AMA descriptor change, the 2016 crosswalk rationale is no longer relevant. The overwhelming data includes the expert panel recommendation, society recommendation, consistency with 81528, recognition of circulating cell-free DNA costs, and recognition of the PMA costs all point to 81288 as the clear reconsideration crosswalk for 81327. Thank you.
Our next speaker is Anthony Cerisi from the Association for Molecular Pathology.
Good morning, everyone. My name is Anthony Cereci. I'm a molecular pathologist at Columbia University, and I'm representing AMP and giving our pricing recommendations for the new and reconsidered codes in the molecular code set. There are a large number of codes that we're going to try to cover today, 37 to be exact. So for presentation purposes, we've divided the codes into 7 categories seen there. Importantly, the handout that you were given in grid format covers all the information that I'll be presenting today, but in the order that's provided by CMS. Because there's so many codes to talk about, we're going to try to do an overview of the approach that we took for crosswalk recommendations. I'll take a step back and say that because there are so many codes these days that are valued and that live on the CLFS and the molecular code set, we're actually successful in identifying codes for crosswalk recommendations on all new and reconsidered codes. The general approach for crosswalk was the same across all codes. A group of experts in molecular oncology and genetics met to identify existing codes to match to the new or reconsidered codes on the basis of analytical and technical methods employed, the overall resources that would be utilized for the testing, and the amount of genetic material that's interrogated by each code. Additionally, the type of genetic variant tested, in other words, single nucleotide variants, deletions, duplications, were also considered. What's not on this slide, but what we also considered was the specimen type, which is assayed by the code, for example, FFPE versus blood versus other body fluids, and also the clinical context under which the code is utilized, so somatic testing in cancer versus germline testing in genetic conditions. So with that, we'll dive right into the recommendations. The first set of codes are the pharmacogenomic codes. There are 7 of them. The first 6 assay a varying number of single nucleotide variants from 2 to 6, and the last one, the TYMS code, detects a repeat expansion variant in that gene. So the purpose of this set of codes is to identify variants which impact drug metabolism and might actually alter dosing on the clinical side. And generally, this type of testing for single nucleotide variants is done by PCR amplification and genotyping mechanisms, or for the repeat expansion, we generally use fragment analysis techniques. So for the crosswalk recommendations, we attempted to find crosswalks in existing codes that assayed the same number of SNPs for the first 6 codes. You'll notice the ×2 multiplier on 2 of those codes, and that's because we feel the resources and time required for the assaying of 1 SNP or 2 SNPs is about 2 times that required for the assaying of 1 SNP. For the last code, the TYMS code, we crosswalk to the FLT3 code, which is another internal tandem duplication code. The next family of codes are the human platelet antigen codes, and there are 8 of them. Each of these codes detects 1 single nucleotide variant in a specific HPA gene. The purpose of this testing is to identify women and their fetuses who are at risk for neonatal alloimmune thrombocytopenia, or for patients who are at risk after platelet transfusion for alloimmune thrombocytopenia. Because this is a single SNV detection assay, all of them are, we use PCR amplification followed by genotyping, similar to what we previously described. And because, again, all the tests are very similar in terms of the type of variant that they detect, we've crosswalked all of them to a single code, which detects one SNV. The next group of codes we'll discuss are the heme-related genetic analyses. You'll notice the color coding on the slide, which groups each of the codes into the category of testing that, under which they fall. So we have full gene analysis, common variant analysis, known familial variant analysis, and then deletion duplication analysis, or del-dup analysis. In general, the purpose of these codes is to identify and diagnose patients who are either carriers or affected by disorders that impact the coagulation and hematopoietic systems. The methods vary depending on the type of variant or the analyses that are being performed. For full gene sequencing, we generally use bidirectional sequencing either by Sanger sequencing or next generation sequencing. For the common and familial variants, depending on the type of variant we're analyzing, it's again PCR amplification followed by genotyping for SNVs, or multiplex ligation-dependent probe amplification, or MLPA, for del-dup analyses. And again, for del-dup analyses, we use MLPA. So for the full gene sequencing codes, of which there are 4, we crosswalk based on the amount of genetic material that is assayed. You'll notice that for the bottom 2, for HBA and HBB, we crosswalk to the EGFR code. And while this is not a full gene analysis code, the amount of DNA or the size of the gene, in the case of HBA, matches with EGFR. And we felt that was an appropriate crosswalk. Under known familial variants, we crosswalked all 3 to the BRCA1 gene, which is currently also known familial variants. This covers both SNVs and del-dups, which are also seen in BRCA. You'll notice for the bottom 2 codes, the HBA and HBB, we have a ×2 multiplier. For these autosomal recessive traits, your autosomal recessive conditions, you're generally looking for 2 alleles, and so that explains the ×2 multiplier, whereas for BRCA1, you're in an autosomal dominant condition, you're only looking for 1 allele. For common variants, for the SNVs, that's the G6PD and HBB, we crosswalk to, based on the number of SNPs identified by the crosswalked code. You'll notice the ×2 multiplier for G6PD because there are 2 SNVs detected. And then for HbA1 and 2, we crosswalked to the Duchenne's muscular dystrophy code because the most common variants are in fact large deletions in HbA1 and 2, similar to the DMD code. And for the del-dup analysis, HbA1 and 2 and HBB, we crosswalked to a del-dup analysis using MLPA. We had 1 GSP code for hereditary peripheral neuropathy. The purpose is to detect pathogenic or likely pathogenic sequence variants or small indels in relevant genes or a large number of relevant genes to peripheral neuropathy, and this is generally done by next generation sequencing at this point. The crosswalk recommendation here is to the cardiomyopathy panel 81439. This was based on a similar number of genes in the descriptor as well as the genomic material assayed. Moving on to oncology, we have 2 hotspot codes, IDH1 and 2. These are hotspots that are commonly seen in hematologic, neurologic, and gastrointestinal malignancies, including cholangiocarcinoma, and can help identify patients for targeted therapy, generally done by genotyping method. For IDH1, which assays 1 codon, 2 variants at 1 codon, we crosswalk to the KRAS code, which is 2 contiguous codons. And for IDH2, which assays 2 distant codons, we crosswalk to the NRAS code, which again is similar in terms of the distant codons tested. Under oncology, we also have the full gene and targeted exon level procedure codes, ASXL and RUNX1. These are generally used to diagnose and prognose in hematologic malignancies, including AML. And this is actually done by Sanger sequencing or next generation sequencing. Again, for the full gene procedures, we matched based on the amount of genomic material which is tested in the new codes compared to the existing code. For RunX1, you'll notice a ×2 multiplier because the EGFR code generally spans 3 exons, and RunX1 descriptor describes 6. The next group of category of codes that we'll talk about are the infectious disease codes. We have 2 viral diagnosis codes and then 1 tier 3 viral genotyping code. The purpose is to identify and diagnose patients with viral diseases or to determine the viral genotype, generally done by amplified probe technique. We've already had a discussion on 2 of these. The first 2 were crosswalk based on the genomic material which is used, so RNA in this case for the assay, and also the number of strains or organisms which are identified by the code. There was also a consideration of resource utilization. And for the last code, the tier 3 code, there is an existing code which describes the diagnosis of multiple genotypes of HPV, and so we crosswalk to that. And finally, under the Reconsidered code, which we just had a presentation on, SEPTA 9, the purpose is a blood-based colorectal cancer screening and promoter methylation analysis, generally by allele-specific PCR, promoter-specific PCR. And the crosswalk recommendation is 81288, the MLH promoter methylation code. That concludes our recommendations, and I'll take questions. Thank you.
Oh, no, I got questions.
Hi.
So you probably obviously haven't had a chance to see your other presenters, or maybe you have, but I'm going to make the assumption that you haven't. But you can tell me if you have, on some of your code recommendations. And so most of these involve why your selection versus someone else's. So, and I meant to bring my CPT book, but you probably know all the code numbers and what they represent anyway. If not, I wrote down them shortly. I know you do. All right, so for the first one, 813X2, there are you all suggested 81215, BRCA, right? Someone else suggested 81275, which is KRAS. Could you tell us why you think that KRAS is not an appropriate?
Yeah, if you could just tell me the code that you're referring to, the new code.
The
descriptor, sorry.
Oh, I'm sorry, 813. Oh, the descriptor of 813X2. Okay.
Yeah.
813.
I just don't have it in front of me.
Yeah. Let me see. I'll go back. Make sure. 813X2. I was getting all confused with 813, the...
Well, so I'll tell you that if it's what I think it is.
I'll find it.
Okay.
So we'll make sure we're talking about the same thing. Okay, HBB, hemoglobin, subunit beta, e.g., sickle cell, blah, blah, blah.
Okay, so
813X2.
the familiar variants. So for the am I right?
Yes.
Yeah,
right.
so for the familiar variants, we tried to be consistent across all the familial variant codes.
Mm-hmm.
And because you can have both SNPs or SNVs, single nucleotide variants, and deletion duplication, we thought it was important to include a code that also contemplated that. So BRCA generally has both SNVs
Mm-hmm.
and del dupes
Mm-hmm.
in its sort of spectrum of disease-causing variants. KRAS does not. KRAS has SNVs in that case.
But as far as the resources to do KRAS versus,
because of the del dupe analysis, the resources are more similar to the BRCA code.
So that would be your answer.
Yeah.
Okay. So now we're on 813X4, which is, again, hemoglobin, subunit beta. This is full sequence.
Mm-hmm.
Okay. Someone else suggested that, make sure I got the right code here, that it could be crosswalked to 81321. Make sure. Yeah, 81321, which is P10 full gene. No.
P10, yeah?
Yeah. Mm-hmm.
So again, just based on the amount of genomic material that's assayed, we feel that the EGFR code is more appropriate in terms of the number of, it comes basically down to the number of exons that are covered by the EGFR code,
Mm-hmm.
which is 3, and the hemoglobin beta and alpha, which are both 3 exon genes.
So you are a numeric kind of guy, like some of the other ones. If it has 3, it needs 3 or 4, or if it...
That's fair. Not necessarily, but the size of the genes are about, the size, the amount of genomic material covered is about the same. You can have a very small exon, right? But in this case, it's about equal, in our opinion.
So how would someone like me, who is totally naive to how much genetic material, I know you know your stuff, but how would I know that 3 exons this small? But how would I know that if I'm trying to make a determination about it, or is it just trust me?
Well, it's knowable. It's
Okay.
There are databases of this type of information, but in general, experts will be able to talk about it and give you good information on that.
Okay. Is that something that, and this is, don't take this as this is a
Please.
question. Is there some place in the industry where certain things are, like, you can go to a list and say this exon has this much name,
Yeah.
like it's published? I mean, like in a one place, not like in 50,000 articles.
There are databases. There are databases. PubMed, the gene function on PubMed gives you a lot of that information. There are other databases that one could use. Happy to provide those.
Thank you. That's a good answer. Okay. Now,
Dr. Hamburg, before you continue, this is Karen again. Can I ask a question related to this code? So why wouldn't you crosswalk this code to 81235?
We did crosswalk to 81235. You're talking about the HBB full gene sequencing?
Okay, I'm sorry. I'm on the wrong line.
Oh, that's
sorry.
okay.
okay. So, my next one. 81X59. Okay, so these are your, these are all known familiar variants, and you have different levels, and you explain why. Some of them, oops, maybe I'm on the wrong one. Wait a minute. I am in the wrong one. Let me make sure. 81X59. 81X59. Okay, let me just go on with my question. I believe you said that you all wanted 81235. Was that your crosswalk? Yeah. And someone else suggested 81321. Any?
81X59 is full gene sequence?
Yes.
So similar to HBB, the hemoglobin B,
Okay.
the amount of genomic material there we felt was comparable to the EGFR code, which is 81235. So they're the same size gene.
Okay, so in general, and I'm just going to go through some of the other ones just to ask you, and you can just tell me if it's the genomic material. That way we can cut through the chase on some of these, and everybody can have lunch. 81X30. You all suggested 81374. Others suggested 81227, which is CYP2C9. So is it, again, the amount of genetic material, or is there something different with that?
So in this case, we looked at this was both a number of SNPs, a number of SNVs detected, but also the resources required for that type of testing. And in discussions, it came out to, we actually did consider the other code, which looks at 2 different SNVs, and came down on this. If for any more information, I'd have to defer to written comment.
So let's go to 81X34, and these involve, people chose 2 different ways to analyze HLAs. You all chose 81376, and others chose 81381. So the locus, and both of them have one in them. I don't know about how big an allele is versus a locus. So do you, in this case, it's 1-to-1. Is it genetic material? Is it the same answer?
Yeah, so there I'd have to look a little more closely to that. At that. But again, the decision to use that particular code was based both on the number of variants that were being detected and the resources that we believed were utilized were comparable across the 2 codes.
Okay, you're almost up. The next 2 are the same, and they have the same crosswalks, 81X35, 81X37. I believe you all selected 81374, and others talked about 81227.
And 81227 is?
81227 is, I had it someplace on here. Oh, the CYP.
Right, right. So
C9.
I'm going to have to, again, use the same exact answer, which is we looked at the number of variants that were detected and then the resources we believed were appropriate and comparable. But in order to make that comparison more astutely, I'll need a little bit of time.
Okay. You only got 3 left. 81X58. I think you all chose 81215, which is the BRCA, and then others chose 81241, which is full sequence gene analysis code. Again,
81X58?
yes. I believe you all chose.
Right, so this is the known familial variant, and so similarly, because in particular for hemoglobin alpha, the variants are most commonly deletions, but there are also SNVs. BRCA felt like a more appropriate, or is a more appropriate crosswalk in terms of the types of variants that are detected and described under the BRCA code. So from a resource utilization perspective, because you're looking for both SNVs and del dupes, it makes sense to use a code like BRCA as opposed to, well, I don't know what the other code was.
812, it says just full sequence gene analysis, 81241. So back to that little offer that you had, those public databases, is there is that listed someplace, like these particular types of codes or analyses are more likely to deal with more SNPs or whatever? Is that someplace publicly available for, laymen like me?
Yeah, I mean, the answer is probably yes, but that
Yes,
just comes
from gene reviews, or the OMIM website. Yes, all that information is, whether it's primarily duplication or deletion or SNV variants.
As well as the number?
It does give yes, it does give percentages. Yeah, it will say 90% are deletion duplication, causes are to deletion duplications, and 10% are due to sequencing variants.
Thank you.
Well, maybe that's something that we might want to consider having brought with us. Okay, very good, thank you. I just love coming to this meeting. I just learned so much stuff here. Okay, the next, got two left. All right, 81.
I had two left before.
Well, okay. Not mine. Okay, 81X59. And I was trying to group them, but these actually have different ones, so we'll have to do them. Okay, so you all picked 81321, which is P10 full gene, and then others suggested.
Well, for 81X59, you said?
Yeah. Did I pick the wrong number?
Yeah, we crosswalked to EGFR, 81235.
Okay, then other people picked 81321.
Which is P10.
full.
Yeah. So it's similar to what we described with HBB, the beta, hemoglobin beta. P10 is a large gene. The EGFR gene appeared to be about approximately the same size as the HBA.
Okay.
And again, in terms of resource utilization, that sort of correlates there.
Et cetera, et cetera. Okay, last one. 81X69. They are both Duke Dells, the comparisons. 81323 times 2, sounds like you, times 2. And then the 81294, which is MCH Duke Dell. And 81323, unless I wrote down the wrong, I got P10. I got the same, it's Duke Dell. Okay, 81323, Duke Dell.
Yes, hang on one sec.
81X69.
81X69, there
69,
we are.
sorry.
Yep, got it.
The Duke Dell one.
Yes, and so we crosswalked to the MLH Del Dupe. And your question
the
is?
other person, other people suggested the P10 Duke Dell, which is 81323.
There I'd have to do a little thinking about that.
All right. Okay, good. So you don't really have a project for me, but this is to the whole everybody. If indeed those databases exist like you're saying, and if indeed it's easy to sort of access and put them together, potentially that might be something that would be useful to the agency. So presentation. Now, I have no power to say anything. I'm just thinking out loud that that might be something useful, and maybe we can talk about that.
Great. All right, thank you.
Thank you.
Okay. How about we take a lunch? We'll break until, we'll reconvene at 1 o'clock. Does that work for you all? Okay. See you at 1.
Yes.
Panel, if you could stay here for a second. Karen would like to speak with you.